away.
Well, thanks, Ed, and boy, what a great setup with our speakers we've already had this morning. And so I want to thank all of the people who have spoken already and our sponsors for this program. So now I'd like to welcome you to Expanding eConsent, the advanced care planning session devoted to defining the problem and opportunity. This session is designed to provide an overview of the advanced care planning process from the perspectives of the patient advocate, regulatory, payer, and provider perspectives. I'm honored to moderate this panel of nationally known experts in the ACP field. I'll be giving a brief introduction of each panelist prior to their segment, so please see the conference website for their complete biographies. And each of our panelists are going to spend about 12 minutes discussing advanced care planning problems and opportunities from their area of expertise. You can use the question function on the screen to enter your questions to the panelists throughout the presentation. And when all the presentations are complete, we will field questions from the audience. This morning, we're going to begin our session with the patient advocate perspective featuring Ms. Julie Wallace. Julie has been a community healthcare advocate for the past 13 years, many of those spent working to promote local advanced care planning efforts in her hometown of Grand Rapids, Michigan. Currently, she sits on the Spectrum Health Biomedical Ethics Committee, serves as a lead volunteer for the National Patient Advocate Foundation, and was recently invited to join the Patient and Caregiver Advisory Committee for a University of Pennsylvania palliative care research project. It is my pleasure to introduce to you Julie Wallace.
Thanks, Carol. Let me just see if I can get set up here with my slides. Ed, I may have to leave this up to you. Next slide, please.
There we go.
Can you all hear me? There.
Yep.
Thanks. Thanks, Carol. And good morning. It's a real honor to be here today representing the patient and family community. Here in West Michigan, the concept of advanced care planning gained real traction around 2013. When Spectrum Health and Making Choices Michigan invited me to add that same voice to their efforts, I jumped at the opportunity. I could sense a change was in the air, and to me that change was long overdue. I realize for many of you, advanced care planning can signify endless legal hoops, platform snags, signature minutia, workflow challenges, EMR nightmares, and so on. But before you get tangled in those weeds today, I'd like to take a moment to reflect on the very essence of this work, which is to give patients a voice and the means to be heard, to connect patient to caregiver with the greatest healing power we will ever have, the power of knowledge. So I'm going to tell some stories for a moment, so feel free to sit back and grab your coffee or your tea and just relax. Next slide, please, Ed. So this is my family back in the early 90s. Over the next 24 years, everyone in this photo would come to know medical hardship, and knowledge in its various forms would become a significant factor in determining each of their outcomes, good and bad. Slide, please. We'll start here with my great aunt, Dorothy Craig, who I credit as our trailblazer. Aunt Dode, as we knew and loved her, suffered a severe head trauma just a few years after this photo session, when she lost consciousness and fell headfirst on her basement floor. With the help of a doctor/neighbor, an ambulance was called and Dode was taken to the ER and on into emergency surgery. She survived, but never regained consciousness. After a prescribed amount of time, she was given a feeding tube and transferred to a long-term care facility. After a few short weeks, she died in the middle of the night without the comfort of her family in a ward she shared with several other voiceless patients. A tragic series of events, but not uncommon to a seasoned medical professional. But for my great aunt and her family, it was anything but common because Dode was a devoted Christian Scientist and had been all of her life. She entered that ER with a blank canvas for a medical history, but that wouldn't be enough to stop the wheels already in motion. And this was the early 90s, a time when it was still commonly agreed that doctors knew best and families knew better than to interfere. So Dode's truth was never told, and we all fell victim to that silence, knowing she died in conflict with the values she held so dear. Slide, please. Slide, please. Thanks. Dode's story turned bittersweet when her husband, my great uncle seated here, received a colon cancer diagnosis just a couple years later. The sting of Dode's experience would influence every decision he made as he navigated his own treatment path. Slide, please. Foregoing the formalities of documents and attorneys, Les simply stated his wishes aloud to each of us and asked for our support and willingness to help carry them out. He started with surgery and a horrific round of chemo that we nursed him through. A year later, when the cancer returned and the doctors recommended a more aggressive approach, Les politely bowed out. Again, he came to each of us for our blessing and support. We collectively agreed, banded together, and with the help of hospice, our neighbors, and loving community, peacefully in the living room of the log cabin, exactly as he had planned and exactly as he had made known. With his passing, Les would establish the gold standard from which I would measure every experience going forward. Dode's suffering had not been in vain after all. Slide, please. For my two sisters, their thirst to know would never be satisfied as they faced breast cancer treatment together back in the early 2000s. It seemed every procedure and round of treatment carried an unexpected setback we were often ill-equipped to handle. We worried constantly and questioned everything. Should things look like this or feel like that? Will this be the last time? The last one? Should we stay calm and wait until morning? Call the office? Go to the ER? Will this be the last day? Will this last a week? What's lurking around the corner? What will the next year look like? What does the future hold? The relationship between truth-telling and cancer is a precarious one. Oncology can come across as wizardry, with doctors practicing behind a mysterious curtain, keeping their knowledge to themselves, often leaving patients vulnerable and uninformed. Some fall victim to this approach, like my dear cousin Julia, who quit halfway through her chemo regimen because for her, the not knowing became worse than the treatment. My sisters, along with many dear friends, powered through but paid a price. And to this day, I wonder how their experiences might have been improved by an occasional peek behind that curtain. Slide, please. These are my parents. My mother suffered from dementia for 10 years before she died back in 2012. My father designated himself primary caregiver upon diagnosis and evolved to become her care lover. Slide, please. A term he coined and a role he embraced and documented until she died in her sleep in the bed they shared for over 55 years. Slide, please. It was no easy feat. My father was not the picture of health himself, and we as a family knew nothing of the hell of dementia. What saved us all in the end was the support of one doctor, a gerontologist who managed my mother's care and guided us along every rocky step of this path. She made it her practice to know everything and everyone, And that made all the difference, because even as my mother's capacity to know diminished, her capacity to trust and love those closest to her never wavered. And her trust in this provider deepened with every visit over every passing year, easing her journey from a life she was slowly forgetting to one she will forever know. Slide, please. And so this is my father, and that's the one person left. By the time he began to buckle under the strain of care loving from my mother, advanced care planning was beginning to take hold. And so with the help of Carol Robinson, whom you've all met, he and I made out his final directive together. Now I knew, and he knew that I knew. Ultimately, the end would be on his terms, but getting there would be a challenge even our best efforts would fail to counteract. Unlike my mother, who suffered from one overarching illness, my father succumbed to a variety of ailments that had coexisted for years, but started on a collision course in the end. This was a crazy-making time for me as his advocate, because his final descent required the support of a team of specialists we met in a dizzying round of regular appointments, ER runs, and hospital admissions. There were little fires everywhere. The heroic efforts of each and every doctor we met kept the flames under control, but proved no match for the overall blaze none of them could see. The blaze that would eventually force their retreat and bring a sudden halt to this rescue mission. With little time left, we jumped from working to save my father's life to preparing for its end. Somehow we managed and avoided getting burned in the process. To this day, I remain grateful for the care my father received. I only wish someone could have seen what was coming sooner, so we might have enjoyed a longer, more gentle approach to the ending my father had originally envisioned and requested. Slide, please. It was Sir Francis Bacon who said, "Knowing in itself is power." Advanced care planning harnesses that power. By completing a directive, we get to know ourselves. In choosing an advocate, we share that knowledge with others. And when we put that knowledge into the hands of our providers, we give them the gift to heal us all. Thank you.
Thank you, Julie. I am always just so touched whenever I hear you speak, because really you bring it home that this is all about people, that we can get caught up in a lot of different things that sometimes we lose the face. So next, I want to move to the patient perspective. And with that, we're going to hear from Dr. Rebecca Sidore. Dr. Sidore is a geriatrician, a palliative medicine physician, advanced care planning researcher, and professor of medicine at the University of California, San Francisco. She directs the Innovation and Implementation Center on Aging and Palliative Care Research and the Vulnerable Populations Aging Research Core of the National Institute on Age Funding Pepper Center. She is also the creator of the evidence-based online Prepare for Your Care Advanced Care Planning program and the Prepare easy-to-read advanced directives, which are available for all 50 states in several languages. Welcome, Dr. Sidore.
Thanks for having me. And Julie, I just wanted to say thank you so much for sharing all of those experiences. I think it's a good reminder of why we're here. We're really here so that we can serve and honor patients. And that was really helpful, I think, to ground all of us back sort of into why we're doing this work. I'm going to build a little bit on that and talk about, again, consent and advanced care planning from the patient perspective and things that we've learned from our research. Ed, I think I'll have you advance my slides for me, if you would. You can click one more time. Thank you. So this builds a little bit on the pillar idea that Jocelyn spoke about in the last session. My work really focuses on behavior change and thinking about ways that we can help get people engaged in advanced care planning. And in some of the work that we've done, we've published these set of pillars, really thinking about advanced care planning and all the things that might go into helping a person engage in the process. And some of those things include the person themselves, but also their, caregivers or care lovers. I love that, Julie, or surrogate decision makers, the community and the social norms that are in that community, clinicians, whether or not they're trained and can reach out, as well as some of the things that we've heard about health systems, interoperability, as well as policy, which we'll hear a little bit about as well. Next slide, please. For some of you who might be new to advanced care planning, why is it important? And I just want to take a moment to say that there's research that really shows that doing advanced care planning can improve patient satisfaction with care and quality of life. It results in less unwanted medical care that is more aligned with their wishes. And I think we're finding, really importantly, less stress for the surrogate decision maker as well. If you go to the next slide. I think when we think about, well, what are the advanced care planning realities? So the advanced care planning rates are still sort of nationally somewhere around 33%. They're higher, sometimes up to 50% in some places in the country. But this percentage really hasn't increased over the last 10 years. And we find that this is much lower among minority and historically marginalized populations at only about 15 to 20%. And when you ask people if they've actually, discussed their wishes with their medical provider, only 10 to 20% have. So some people might have these forms at home or been thinking about these things, but haven't really even brought it into the medical environment. And in one study that was done actually at UCSF, it showed that sort of people who had died in the ICU, so ICU decedents, about 20% had absolutely no advanced care planning on file before death. Next slide. So I think we've got challenges, and I think that these are really opportunities, and I'm going to go through each of these. So I think it's really important, as we're also thinking about the technical interoperability stuff, we have to also think about the content and what are we giving to patients to help them sort of engage in this process. So I think it's really important that we think about outdated models of both consent and advanced care planning and how we're going to meet the challenge of the new models. It's important to think about health literacy, language diversity, cultural diversity and real disparities that we see, digital literacy, legal challenges, and finally I'll end with some specific COVID-related challenges. Next slide, please. So when we think about outdated models of consent in advanced care planning, the old model of consent was, here is this form, read it and sign it, give it to me, and I'll just do this procedure or we'll just move forward. And the old advanced care planning model was sort of this one-time advance directive, a DNR order, I check the box, I scan in this form, and I never have to talk to you about this again. Next slide, please. But new models, so when we think about informed consent, there was this 2020 systematic review of what they called enhanced informed consent. And when they looked at actual comprehension, you got 43% with written interventions, which when you think about from a patient safety perspective, if less than 50% of people understand what you're doing, that's a problem. But that increased when you added in audiovisual interventions. It increased to 67% with multi-component interventions, and more importantly, up to 100% with what is called teach-back interventions. So this is an interactive thing that happens with a clinician over time, and this is really the new model. So when we're thinking about informed consent, things like places like the VA have really integrated this into their system, but how do we allow clinicians to dynamically document whether or not somebody understands what's being given to them? And if you go to the next slide. Same thing with advanced care planning. So this was a consensus definition that was published just in 2017 from international advanced care planning experts. And again, instead of a one and done form, in this new model, advanced care planning is defined as a process that supports adults at any age or stage in health in understanding and sharing their personal values, life goals, and preferences regarding their medical care. And again, this is a dynamic process. And so I think that kind of patients being able to look at and update their wishes, being able to update updated advanced directives, and not thinking about this as one checkbox. Next slide, please. So I'm going to talk about health literacy. So this cartoon says, you don't call this a legal document, do you? I can understand every word of it. And we see this really with consent in advanced care planning. Next slide, please. So health literacy considerations. You may be interested to know that the average reading level in the US is only at the 8th grade reading level. And for people receiving Medicaid and the elderly, it's only at the 5th grade reading level. However, advanced directives and consent forms are consistently written beyond a 12th grade reading level. This is a picture of an example that was being used at our county hospital. And research that we and others have done have shown that limited literacy results in poor understanding of both informed consent and advanced care planning. Next slide. This is something that was published in New England Journal of Medicine in 2017, talking about the common rule of consent, and I think this applies to advanced directives as well. It has long been recognized that under the current rules, consent forms have been growing longer and can be difficult to understand. They too often appear to be designed more for protecting the legal interests of institutions than for helping someone make a decision. And that is definitely true of advanced directives as well. Next slide, please. There is language diversity. So 61 million people, or about 20% of our population, speak language other than English at home. This includes 40 million Spanish speakers and 3.4 million Chinese speakers. And we've shown that if someone is a non-native English speaker or they have diverse language, that this results in poor understanding, again, of both consent forms and advanced directive information. Next slide. Cultural diversity and real disparities. So there are many people who hold what we call non-Western views on autonomy and decision-making. So in our work, we have found that 20% of people will report that they don't want to make their own medical decisions and they defer that to other family members. So if that's the case, we have to think about, well, how do we engage them in advanced care planning? How do we engage them in informed consent? And so I think this is really important to think about. And we've definitely included in our Prepare for Your Care work. I think it's also important to realize that there is real experiential racism and mistrust. We see this a lot with advanced directives, and people are very weary of signing legal forms. And so thinking about other ways to document people's wishes if they're not willing or able or want to fill out forms. Next slide, please. We talk about digital literacy. So this is information from the Pew Research Center that showed that about 73% of older adults, those 65 and older, report that they use the internet. And that's great when we're thinking about eConsent and getting onto patient portals. Yet only 60% of those were able to actually send an email or fill out an online form. So that means that 40% of people over age 60 may not be able to fill out an advanced directive online or deal with the MyChart and other patient portals. Next slide. Not surprisingly, that digital literacy also sort of exposes many disparities. And so the Latinx population, people who don't speak English, and those 65 and up, and those in lower socioeconomic status have limited basic digital literacy. Next slide, please. So again, getting back to patient portals, I think that what we found through research is that only 50% of patients 50 to 80 years old access patient portals. 84% of them do things that are passive, like check labs, and much less do things that are active. So 37% schedule an appointment, only 26% get an advice. So just again, something to think about. Next slide. And so I think when we think about the digital divide and even video visits, because some people will say, well, let's do informed consent by a video visit, let's do advanced care planning by a video visit, or pulsed through a video visit. So a lot of times people do not own an enabled device, so they have limited access. We've talked about digital literacy, not knowing how to use an advice. And I think really importantly, as a geriatrician, it's important to sort of talk about the fact that usability is a big problem. So hearing, speaking, seeing, and cognitive impairment are real barriers to older adults. So in these studies, they found that 38% of older adults are not ready for video visits. And again, sort of minority populations and people with limited socioeconomic status, and even people with poor health, the people that we're actually trying to help, 77% of them are not ready for video visits. Next slide. So I think there's legal challenges. So Pooja touched on this earlier this morning. So each state has their own laws about advanced care planning and advanced directives. And there have been many attempts made through the American Bar Association and other organizations to get everything standardized. And states sort of have all of, they want to retain those rights to make their own laws, and it makes it very challenging. And so as Pooja was talking about, there's a lot of execution barriers. So some states and a lot of organizations do not allow oral advance directives. And again, so even people who don't want to fill out forms, it's hard to collect that information and put it into the medical record, requiring witnesses or other signatures, and some states require notary as well. Next slide. So I think the good news is, and I think I really want to sort of encourage you all to think about the fact that you can address these challenges in addition to your technical challenges. And as an example, our prepareforyourcare.org website sort of walks people through the advanced care planning process. We've created easy to read advanced directives in multiple languages for all 50 states that can help people understand and can help engage them in the process. We've done randomized control trials that show that providing this information can engage 98% of diverse patients in advanced care planning. So you can make these changes, and it does really impact patients' ability to access information and understand it. Next slide. I just want to end that there are particular COVID challenges that we found, particularly for advanced care planning. So social distancing and socially isolated adults have been unable to get witness, signatures or notary. I think we've also found that many states do not allow virtual notaries. And so this results in people who might even want to engage in the process, but they can't get the forms legally executed. And many systems are not set up for clinician signatures for pulse forms. Organizations like VINCA are working on this, but many organizations still are not set up to do this virtually. So next slide. So I just want to end, by reminding you again that thinking about these things that we need to be aware of, thinking about outdated models and making sure we're using the most updated process models of advanced care planning, paying attention to health literacy, language diversity, cultural diversity, digital literacy, and legal and technical challenges, as well as COVID-19 related challenges. Can you click next? I think I teed up Linnell for the next, well, just to say when Linnell talks, he's got some really great slides on some of the technical challenges, and he'll be going over that with you. But thanks so much, and I'm learning a lot from this session as well, so thank you.
Okay, thank you, Dr. Sidori. What a great overview in a short amount of time. You really did a great job of putting yet another face on the challenges before us. So next up is Dr. Sherry Ling, and Dr. Ling currently serves as the Deputy Chief Medical Officer for the Centers of Medicare and Medicaid Services. She's a geriatrician, gerontologist, and an internist. Thank you for joining us today, Dr. Ling.
Oh, indeed, it is my pleasure and honor. Just checking sound. Are you able to hear me?
You're good.
You're loud and clear.
Okay, perfect. Thank you. And thank you for my first slide. It is indeed an honor and always a daunting task to follow Rebecca. But really also want to say thank you to starting off this session with a focus on patients and families, those those patients and families that we heard about really are also our beneficiaries. So I've been asked to make remarks representing the regulatory perspective, and so I will do so. If I could have my next slide, please. So, but before I do need to show my say that I have no financial conflicts to disclose other than I work for you, the American people and the public. I will also make remarks that reflect where we have been, what the opportunities are, just recognizing there are numerous hurdles and barriers to overcome as we look at the journey of patient preferences and goals and how to implement. But I'm going to try to focus on what the opportunities are. And next slide, please. So just by way of scope, where CMS is connected to this entire system is in several different ways. As I mentioned earlier, I've been asked to really remark on from the perspective of a regulator, but also we are a payer. So I'll start with regulator and then move to payer, and also tee up James for his remarks. CMS actually, through programs and policies, and all of the different levers that Centers for Medicare and Medicaid Services has authority to implement through, we touch upon the lives of approximately 1 in every 3 Americans, and the population that's served by CMS is increasingly complex and increasingly enriched with people with multiple chronic conditions, multiple comorbidities, and a true need and opportunity for us to impart the preferences that people have in determining how their journey will go over time. So this is not, my remarks are not about the end of life per se. My remarks are not about just a advanced directive. I'm going to try to keep it a little broader just to illustrate what some of the opportunities are and the challenges. Next slide, please. So there are several programs and policies that CMS has authority to implement. I will focus first on what is shown in yellow, which really is about the regulatory role that CMS plays. And to say it, the conditions of coverage and for participation are those that set the minimum safety and quality standards for all participating Medicare facilities or providers, ranging from hospitals all the way through hospices, end-stage renal disease facilities, nursing homes, and everything in the middle. And those in those safety and quality standards, because we are mindful and cognizant of the variability and the flexibility needed to really implement in a way that would suit the needs of the populations of people served by those providers. We really do try to remain flexible, but in that flexibility also call out that most care providers already have an expectation to pay attention to care plans, care preferences, and it is imparted in the rules of engagement or the conditions of coverage or participation for Medicare. Now, I will also say, because of the variability between provider types, it can look rather different, and they're calling out the opportunity to really focus on what would be the required and standard data elements that could help to populate advanced care plans and care plans in a way that could be measurable and implementable across care settings or even within care settings. All in all, however, it is preferable that there's standardization that would also permit translation from one setting to another. And really delighted that our ONC colleagues were part of the panel earlier, because this is about transfer of information at the points of care transition, which all of our beneficiaries at some point really experience. Now, one of the gaps that the COPs and CFCs have is that CMS and Medicare do not have stated quality and safety standards for physicians or physician practices, and that is laid out in the statute. So there we look to other levers and programs to be able to send a signal that advanced directives, care planning, goals of care, these topics and conversations really matter. And as we move towards away from fee-for-service and towards a value-focused payment construct, I think there will be enormous and real opportunity to really make that a robust representation of what we believe is not only possible, but really will serve our beneficiaries well. Now, the other part of the yellow is, so these COPs and CFCs are what the surveyors actually look at when they are assessing compliance and are enforcing to. And this is across, each provider type has its own type of recipe for compliance assessment, but and also timing varies, but by and large, that is the back end of these stated expectations, if you will. So next slide, please. So now we also have built-in opportunities to focus on care planning and advanced care planning as a payer, and have included this topic, this opportunity in the annual wellness visit. So in a way, annual wellness visit is actually a preventive health benefit. So thinking about care planning, goals of care as part of preventive actions is a signal that we already sent, and it is defined, the details are defined under the physician services and Medicare Part B payable service that can be provided by not just physicians, but also physician's assistants, nurse practitioners, clinical nurse specialists, and the like, as well as other healthcare professionals who work ideally as part of the team and can provide services incident to that of the attending physician. Next slide, please. Now, the details are also imparted in a advanced care planning billing code or codes. These details appear here and are available for through our Medicare Learning Network documents, and you could actually identify and find these by way of these specific CPT codes, but can also be found just by Google searching CMS or Medicare and advanced care planning. So hospitals, physicians, and also other healthcare providers may bill for these services if the practice within their scope of practice and are within the construct of a Medicare benefit. Next slide, please. Now, importantly, it is not just about the payment, but thinking of this as a topic of quality measurement. And if you think about transition into value-focused payment or value-based payment, it is putting quality and cost on the same page. And as such, just highlighting for you that we already have a NQF endorsed quality measure on advanced care planning, but there are also this measure and other measures are being used in the context of different episodes of care or episode-based payment initiatives that CMMI has been testing, the Centers for Medicare and Medicaid Innovation. And again, moving away from fee-for-service into alternative payment models is the direction that we've been really focused on evolving. Next slide, please. Now, this is my final slide, and this is just to illustrate where advanced care plans and care planning and eConsent and all of this fits into the meaningful measures construct. We lay out um, what we have created as far as domains that specific quality measures fit into. And this all helps to support MIPS value pathways for specialty care, for general and primary care, and also other constructs of health services and health care delivery, but again, all in the evolution towards value. Now, I know Dr. Michelle Schreiber will be on a panel later today, and no doubt will be speaking to some of these opportunities as well. And with that, I will close and thank you.
Okay, thank you, Dr. Ling. What an excellent presentation. So much information. Everybody's been doing such a great job of making it more understandable for us. Next, I'm pleased to introduce Mr. Linnell James on the payer perspective of advanced care planning. Mr. James is the business leader for Health Information Exchange and Innovation at the Blue Cross Blue Shield Association. He has over 35 years of experience in health IT, with the last 18 at the association as part of the National Electronic Standards team. He was recently elected to the HL7 board and serves as an advisor to the program management offices of both HL7 Da Vinci Project for Value-Based Care and the HL7 Gravity Project for Social Determinants of Health. Mr. James is also a member of the coordinating committee for the ONC Fire at Scale Task Force, also known as ONC FAST. And finally, prior to joining the association, Linnell spent 5 years as the acting deputy director of clinical systems for the third largest public health system in the country. Thank you so much for being with us today.
Carol? All right. Thank you, Carol. Hopefully you can hear me okay. All right, everybody, welcome. I'm so happy to hear that Rebecca and Dr. Ling had done some of the preamble that I want to talk about, and Jocelyn too, in terms of looking at the problems and the opportunity from a payer perspective. On the next slide, it really talks about my agenda for today. I want to focus on some of the industry activities that you've heard from some of the previous speakers, give a payer perspective on some of the regulatory issues, and then really do a slightly deeper dive into standards. Some of you that know me know that it can be a little bit challenging, etc. And I get you'll pause for a minute while I go. I'll be talking, but I've got to disappear off the screen to make sure I don't lose power. But one of the two stories I wanted to share with everybody was a little bit of background for when I was active at HIMSS in 2018 as part of what Jocelyn knows as the challenge of getting Da Vinci going, was talking to many of the stakeholders as part of getting Da Vinci started and making sure that everybody, all the appropriate stakeholders were participating. And one of the vendors that I talked to, I just wanted to add that as part of that process, had an opportunity to talk to a vendor, and in the room with me was the CEO of one of the advanced directive vendors, because even back in 2018, 3 years ago, there was a recognition that using some of the advanced API technologies that you see with Amazon and Hotels.com made a lot of sense for the healthcare environment, which in this case would be FHIR, HL7 Fast Healthcare Interoperable Resources. The other thing I'd like to share, in addition to my involvement in some of the consent and advanced directives for several years, is a quick story on standards. Some of you, going back in time, if you're a history buff, talking about the intercontinental railways. In the beginnings, as some of you may know, that as you went from state to state or territory to territory, they literally had to stop the train, lift it up, change the wheels because the train tracks had a different grade. And so they had to stop and do that. And people realized we can't get interstate commerce if we don't have standards. That was one of the examples for the ANSI, the American National Standards Institute, whether it's your light bulbs, whether it's your train tracks, or whether it's your healthcare standards. There is a federal group that certifies who are standards development organizations to make sure things are interoperable in a variety of ways. And that's a big part of what I want to discuss about how we make sure this effort for eConsent and advanced directives travels on the same rails that are being built and existing now. Next slide, please. Luckily, Jocelyn gave a little bit of preamble. This is one of the ONC slides that talks about the industry's collaborative efforts. On the left, you can see Da Vinci that you heard about, and I'll talk about that a little bit more later. But there's the Argonaut project that made sure all the EMR vendors had the same way to do their apps. Caring Alliance looking at the consumer, Gravity looking at social determinants of health, and Codex looking at the challenges of cancer research to the left. In the middle, you'll see a variety of the stakeholders that are involved in the interest in sharing information, and to the right, trying to make sure we can do this at scale with a newer technology like ONC, like Fire at Scale Task Force. Next slide, please. This is an example, and I know it's a bit of an eye chart, but I just wanted to give you a sense of the broadness of the looking at the challenges of the industry. At the very bottom of the screen, you'll see some of the various tiger teams that have been involved in things like security, privacy, looking at exchange standards, looking at certification. And then in the middle, you're talking about looking at the infrastructure to make those things work. And then we've got some, in the ONC FAST process, some infrastructure solutions that are now on their second or third iteration and are starting to go from written to being brought to HL7 as formal projects to move having these APIs and payers and providers and vendors being able to exchange information interoperably is in process. Next slide, please. And again, just trying to give you a sense of the rails and the progress that can be made. Jocelyn mentioned use cases in her earlier presentation in this eye chart, and I'm not expecting you to look and understand all of this, but to realize there is initiatives going on for reducing burden for providers to the left. There are in the middle a variety of use cases and standards being built for members to access. And then for clinical data exchange on the right, for payers and providers to exchange data is a big part of use cases that are in process. And at the very bottom right, you'll see there's some of these boxes are in a dark red. These are covered in existing or proposed CMS rules. There's been a lot of changes in just the last several months, and one of them is the CA, Consolidated Appropriations Act, which funded the federal government. That's the 5,000-page document, for those of you who've seen it or heard about it. And in that 5,000 pages, there's a section on HHS. And that also has, at Congress's move, more things to drive interoperability for the industry. Again, my focus here is describing the rails where eConsent can live on. Next slide, please. This is to give you another sense of the stakeholders that are involved. Just going left to right at a high level. On the providers to the left, there are providers here many of you will recognize. So the East Coast, the West Coast, Chicago, Texas, all represented. The EHRs in the middle, you'll see many names. If you don't think you've seen ECW in Allscripts, they're actually there. Helo is part of ECW, and Veradigm is one of the ways Allscripts shares their information. And at the bottom of deployment, that's the people that are involved in exchanging information, whether it's availability for claims-based information, Change Healthcare, very involved, and MyHIN is part of the challenge of moving things and how does an HIE work. So deployment has those real-world intermediaries involved, and at the top, at the far right, the payers. You'll see all of the major payers are involved in this. As you look at CVS Health, many of you know that's Aetna. So all the major payers are in there, along with the association, and 9 of our blue plans actively participating. In the vendor space, it's everybody from people who process claims for providers and payers, people who are involved in risk adjustment and risk management, people that are involved also in population health, and then our industry partners with DaVinci, NCQA, and HIMSS. So you've got, and I say all that just to give you a sense of, on these rails and tracks that we're providing, the payers, the consumers, and the physicians and the caregivers. This is the ecosystem of some of the larger entities that will be part of this process. Next slide, please. This is one of the use cases that's, and this focuses on the implementation guides that support the patient-directed APIs as required by the CMS rule, and I'll discuss a little bit more. But I just wanted to highlight for the IGs so you would understand all the key stakeholders that we're talking about in this eConsent process. To the left, the providers. Next to them, the payers that are involved in interacting with providers. To the far right, the individuals who may have an app. And again, in light of the previous presentation that talked about the challenges of some people accessing this technology, realize in some cases it's the community-based organization or a community health worker, whether that person is hired by the physician in the health system or hired by the payer, that would be in the community interacting with that consumer. So the individual may not need to have their own smartphone that can be brought to them, or there can be a portal, so it can be something on that a consumer can be walked through. So there are some opportunities to bring technology to all the appropriate stakeholders. And in the very middle, you can see some of the IGs that exist. There isn't yet an advanced directive IG. There may not need to be one. It could be added to some of the ones that exist. But again, trying to give you a sense of the environment and the payer-provider interest to make sure that we're all on the same tracks as we move forward in this process. Moving to the next slide, please. We talked about the regulatory impact, and this is just the sample on the patient access in terms of an example of the broadness of who it applies to in terms of Medicare Advantage, Medicaid, the CHIP program, if you're a qualified health plan on the federal exchanges. In many cases, these rules apply to that infrastructure. That the CAA that I talked about, that new law that's been passed by Congress, for the most part, expands that to commercial business. So there's an entire ecosystem of payers that are reacting to federal rules and using this new technology. But in addition, ONC, from a standpoint of the vendors, is putting in requirements that vendors provide, and hopefully out of the CAA, there will be incentives and support for the providers to adopt more of these technologies. A little bit of carrot and the stick. The stick for the payers, a carrot for the providers is my informal, impromptu content there. Going on to the next slide, just giving you a sense of these rules and the fact that they're coming into play in July of this year is the first round of these that are affecting the government payer programs, and it's coming in the next year or two to the commercial side and to the providers also. Let me shift gears now to the technology. And so I'm highlighting, and for all, and the way the slide's showing, as I've gone, and I apologize for not mentioning before, when you get access to these slides, there are links at the bottom of the slide so you can do a deeper dive, whether it's Da Vinci or whether it's information that I'm sharing now on some of the applicable standards. There's a blog associated with what I'm going to summarize, so you can go into a deep dive. You can come to HL7 and actually see the whole hour-and-a-half presentation about security and privacy. But as you can see on this slide, you've got the user with the assumption it's an app, and these are some of the issues that standards have to address. Is it secure? If I'm sharing my PHI, PII for HIPAA, am I sending it someplace and is it secure in transport? To the right, where does this data come from that I'm accessing? Did it come from the provider? Did it come from the payer? Was it collected in the community? What's the provenance and source of that data? But I've highlighted with the green tags for this environment, when we're talking about consents, what is the patient allowed and how is that electronically identified and exchanged, and what just happened? Who asked for it? What were they using it for? There's been work for well over 5 years at HL7 looking at this technology and trying to figure out how we use it effectively in the field, and this technology then interacts with the Fire at Scale Task Force, which is looking, how do I do this across the country and do it interoperable for everybody, is the heart of this need that's being addressed. Next slide, please. One of the things that the payers and providers and vendors are going to need is an access control engine, literally looking at the context of who's asking for the data. Is this a break at the very top? Is this a break glass issue? Is this part of regular workflow within the institution, regular workflow in prior auth between a provider and a payer, and what role would the consumer have in that process? To the left, there's the issue of who is the user of this data. In essence, is this the consumer? Is this a caregiver? Is this a care coordinator, which might be in the payer world or in the provider world? For this audience in the middle, for the patient, what have they consented to? Who's on their care team? Who might they have delegated access? If it's an elder citizen, is it their niece? Is it their uncle? Is it a local community worker? And then lastly, to the right is the resource. What are the actual fire technologies that actually allow us to know how's the data tagged, what data is this occurring, what class of access is being provided? All of that needs to be handled by technology. In this case, access control engine is the thing that would use the standards that get built at the standards organization. If we go to the next slide, we'll give you a sense of some of the kinds of challenges that I wanted you to not necessarily be able to use, but understand from a case of standards for the industry. There are a variety of things that are to automate this. We're doing things like, what's the time frame for that consent to be valid? Whether if it's at end of life, that's a much different time frame than if you're middle-aged with some chronic conditions and the consent is timed to who's that particular provider. Who's that consent apply to? Who's the custodian of the data? Let's move down a little bit to what's the purpose of use? Is it related to that care? Is it related to that care coordination episode? And then the tagging the data itself. What's the sensitivity of it? How can it be tagged? What's clinical content? And last but not least, who authored that content? Because over time, we're hoping in this technology, the consumer, the patient who wants to do advanced directives, they hopefully are the author, or someone on their behalf is authoring it. This is just giving you a sense of the complexity of the technology that has to be standardized, and it gets hit by the challenge of not only is this complex, but adding on local policy rules, which is in the middle of the screen, is also a big part of the challenge of making this work in our real world. Next slide, please. and love the time delay. Oh, and one last closing thought in terms of some of the observations as we're, oh, there we go. There's my wrap up. One of the challenges is the pace of change. It was mentioned earlier about the federal rules. Turns out there's some new laws from Congress. There's a variety of in-process work that's being implemented. As I mentioned, there's a July 1 deadline. There's another one coming up for January 1st of 2022, where payers will be exchanging with payers as the preamble for providers to be part of that as one of the other upcoming rules. Regulatory implications. Part of the regulatory side of this challenge is going to be who has what deadlines for what piece of the process, whether it's the standard being available and published and tested and ready to use, whether it's the fire at scale work, so that we're real clear on how this technology will move stuff across some of the intermediaries that may need to be involved in the transaction, and what part is training. And for example, in one of the CMS regulations, it requires that payers are very active in educating their consumers on how to use these new tools. That same process for educating the consumers could be used, if the timing's right, to be part of advanced directives and consent education. Last but not least, the maturity of these standards. Some of you may know the VA has been very active in this space and has implemented some technology, but the VA is run by the federal government. They get to imply, have some rules that imply, and they kind of don't have to worry about the variability of the state rules in their facilities. But for the rest of us in the commercial market or state programs like Medicaid, we do have to pay attention to the state issues, and that adds a high degree of complexity for the implications of these rules. My closing thought is in many discussions, several of the payer members of Da Vinci have had, and some of the payer members of the association's family of 36 plans, we've talked about, kind of crawl, walk, run. It's very easy to come up with a very complex set of approvals and authorizations, very difficult to implement them. So it's kind of important in this case to, have the federal government be involved in making sure there's a crawl, walk, run strategy so that we can get this up and running versus making it so complex. It takes us 2 or 3 years to get it out the door. We really need this based on the people's personal experience, as we heard earlier. We need this now. So if we're going to get it now, we want to build off the technologies that I've described, some of the efforts that are underway, and understanding the implications of some of the new federal laws and some of the new requirements from CMS will all be part of making sure this is something that can be done and align with existing work that's underway. Thank you very much. I'll be around for Q&A later.
Thank you, Linnell. I don't know if you saw Jocelyn's comment, but she said you're a human Rolodex and a Malcolm Gladwell connector, and after that presentation, I can see why. So thank you for sharing your expertise.
Thank you. Appreciate it.
Okay. Yeah. Next up, we're going to reflect back to the beginning of our panel presentation when we heard the patient advocate perspective on advanced care planning, and come full circle to hear from a physician who regularly has to facilitate the sometimes difficult conversations regarding serious illness. It is my pleasure to introduce Dr. David Wang. He is the System Director of Palliative Medicine at Scripps Health, where he leads the value-based expansion of palliative services across 5 hospitals and clinics. Dr. Wang holds national leadership roles at the intersection of emergency medicine and palliative care. Thank you for sharing with us today, Dr. Wang.
Thank you, Carol. And mic check, am I coming through okay?
You're loud
perfect.
and clear, thanks.
All right, thank you. It takes a village. Well, I really appreciate this opportunity. I'll just start by saying I think I'm rounding out the group here, and I don't have any slides. I think everyone's running a little bit short on their attention span at the end of this stretch. So it's my charge to keep you entertained and share a provider perspective as to kind of the importance of what we're talking about. And let me just start by saying I want to draw a distinction between the outcome that we hope for with this work, which is helping patients and their families understand what's coming, make decisions about what kind of care is right for them, and then have that care executed. versus the end user for a lot of these tools that we're talking about today, which I would argue is actually the person who's going to be meeting that patient in a time of crisis, the healthcare provider. And that's really the end user. And let me start then with the patient story. It's quite timely. This is somebody who I just saw yesterday on service. A 33-year-old man who our palliative clinic had followed for a while and was just sent home from the hospital 4 days ago with hospice services, came to our emergency department just yesterday. It was about 9:30 in the morning. The patient was breathing very quickly, had a very rapid heart rate, was confused. And in terms of looking at their litany of diagnostic markers and vital sign derangements and medical problems from their underlying illnesses, it was kind of a diagnostician's delight. There were so many things to do for that patient. The emergency physician took action immediately, as they were designed to do. They heard from the EMS, the ambulance personnel that transported him, that he was a hospice patient, but the patient did not come with any sort of post form. That's what we use here in California, designating any sort of sense of wishes. And so an extensive workup was begun, including all sorts of imaging modalities and blood draws and IV therapeutics. Fortunately, since the patient was known to us, our team was able to intercept them early. And we were able to connect with the family. Turns out this patient had never shared with his family, his parents, that he was dying and why he was on hospice. So family, when they saw him change, were really confused. They sent him to the emergency department. And so we had a very extensive conversation with them by phone, broke bad news, and we were able to clarify that he had signed a post just a day ago, obtain a copy of that, sent to us, and then negotiate with the emergency physician on really de-escalating the amount of care that had already been started. A lot of pushback there. You know, I don't see this document. It's not scanned into our system. I didn't know about that. Are we sure they wouldn't want IV fluids? What's wrong with just doing a CAT scan, et cetera, et cetera. But ultimately, we were able to get the right thing done for the patient, avoid an admission to the intensive care unit, and send him back home, which his father said was just where he wanted for the last few hours of his life. And I think this story to me really highlights a lot of points that I hope to share with you today from the provider standpoint, which is I so appreciate all of our panelists, my co-panelists today, in helping this collective group think through how to design the best possible tool to ensure that patients have their wishes followed. But at the end of the day, we also have to be cognizant that sometimes, you know, even if we build an excellent hammer, for instance, the end user may be thinking they need a screwdriver or not even realizing there's something to do at all. And when I think about this case in its entirety, the question that I always ask myself is, how could it be that somebody with legal documents that identify they wouldn't want certain care ends up getting care that that wasn't ideal for them? And several of the panelists, including Rebecca, talked about how important it is to have these conversations, that they're high quality conversations and they're documented in a way and accessible in a way to various providers on the front lines. You heard in this story that probably the first link in this chain was the emergency medical services personnel. They didn't ask for the post, which did exist. Sometimes they do ask for it, or it can't be accessed, or sometimes they can access it, but they misinterpret it. In recent studies, we found with EMS providers, and that's paramedics as well as EMT intermediates and basics, more than half of them actually misinterpret the documents, especially the do not resuscitate and full treatment scenarios, often rendering care that is too much or too little beyond what is desired. More than 80% of EMSs surveyed, they believe that somebody with a do not resuscitate code status actually means that the patient is comfort care, that they wouldn't want any sort of care at all, for instance, antibiotics for a simple reversible infection. When we surveyed them, fewer than a third have shared that they've ever had any training how to interpret end-of-life documents. We spent all this time ensuring that our posts are accurate, that they're scanned into the systems and they're accessible. In San Diego, we're fortunate to have actually a citywide registry to be able to share these across health systems. Even still, when the document is in the hands of the frontline provider, It's only as useful as it's interpreted to be. So that's kind of the first link in the chain. Then the next step in the train is when they get to the emergency departments. And then again, when we've surveyed emergency physicians and emergency providers about how they interpret these documents, we find a similar kind of story. Huge amount of variation understanding the difference between comfort care, do not resuscitate, and or full care, and anything in between. And by the time they get to the emergency departments, as we heard from, I think, one of our first speakers in the day, they're really under a time crunch. They don't necessarily have the ability or the time to go look through the chart, mine it for previous documents or documents at other systems. And then the third problem that happens is, let's say we are able to elucidate their wishes in the emergency department, but we then find out that the patient may benefit from kind of an intermediate measure or perhaps surgery, draining fluid from the lungs or from the abdomen that might help them breathe better, feel better, or maybe a surgery for a thing that can be fixed. Sometimes hospitals then have policies that require that DNRs be reversed, and then after surgeries occur, there's often a period of time where surgeons are very interested in keeping their patients alive for good post-operative outcomes and somewhat reluctant to have that co-status be reverted to what they truly wish. In medicine, we call this the Swiss cheese model of errors. How does an error happen? It could be at any step of the chain where a patient gets the care that they do not wish. And when we talk today about all these different tools that we have available and this incredible brain trust that's forming to move eConsent and advanced care planning forward, I just want to really reiterate that tools themselves and even education around those tools are only part of the solution that we should keep in mind in terms of arriving at the right outcomes for patients. There's a few barriers. The first is, in the case I shared with you, EMS is always going to be an important part of this conversation. Excuse me. EMS has the infrastructure to deploy last mile care in a way that most health systems and even community-based health delivery paradigms have some trouble with. EMS is ubiquitous. Everybody knows what it means to call 911. And ingrained in our animal brains, when we're scared, when the father of this 33-year-old patient saw his son changing and dying in front of him, his first call was not to the hospice agency or what he thought was home health. It was to 911 because they come fast and he knows that they help people. And so when we think about how to make these tools as useful as possible, we have to think about kind of how they'll be used by this frontline provider population. One of the second big challenges, and I'll just share 4 total before I give up the rest of my time, is about incentives. How do we incentivize frontline providers to deliver the right care, to use these wonderful tools that we've made so much progress on? When I think about this, I think of a seesaw. On the one end of the seesaw, it's giving the right care to the patient, doing the right thing. We all are intrinsically motivated to do this. On the other end of the seesaw are all the things that get in the way of delivering the right medical care for us as providers. One, it takes a lot more effort to do. That effort translates into needing time. In the emergency department, you're beholden to metrics of how quickly you can facilitate throughput. 3 hours from the moment somebody arrives at your door to the moment they go where they need to go, be it upstairs into the hospital or home. In those 3 hours, you have to decide what to do for them, talk to them, order tests, interpret those tests, and arrange for the details of that transportation to the next level of care. It's not a lot of time. Asking someone to spend 15 minutes to look through the chart for something that's fairly obtuse can be really difficult. And let's be realistic. That extra time, unfortunately, also ties into their pay. There's a financial disincentive sometimes to spend the time to do these things. One of the emergency departments in our health system, the entire group does not make a cent for the amount of hours they spend at work. They only make any money for the amount of patients they see. And so when I'm speaking with them and saying, can you please hold this patient for an hour while I talk with family, I realize that I'm actually impacting their bottom line in a material way. And so I have to be respectful of that, even if I feel like the incentives are misaligned. And then, of course, there's always the specter of litigation. The tools are great, but the tools must be designed and accessible and clear in a way that and mitigates the risk of this. Defensive medicine is something I'm sure many of you, if not all of you, have heard. Unfortunate for emergency physicians, there's now also an increasing burden of litigation against delivering care that is unwanted. So resuscitating when the wishes are cleared to not be resuscitated, for instance. And so it's a tricky situation they're in. Designing our tools to be as easy as possible is helpful. The last two factors I'll talk about are a little bit more kind of ambiguous and less concrete, but also very important. You know, we assume that everyone in the healthcare system and the various stakeholders in healthcare are rational agents. But as the field of behavioral economics will share with you, and that's my background, is that we are often not rational agents. And there's a lot of gray in the practice of medicine, especially around wishes at the end of life. First of all, the language that we use is very complex. Many advanced directives will use the phrase choice not to prolong life. That may provide a sense of wishes on what is important in a scenario where someone's been sick for a while. But in that moment of crisis, for the EMS provider or for the emergency department provider, prolonging life is very unclear. Does that mean resuscitate with an opportunity to see how they do? I'm glad somebody agrees with me. And then prolonging life sometimes can be conflated with prolonging death. What is life exactly? What quality of life? We often hear that people are fighters. Our follow-up question to that is always, what are people fighting for at this moment in their illness now? And of course, the verbiage, how we introduce and confirm decisions outlined prior, a provider may say, well, you know, what do you want us to do everything for your loved one? Or they may be asked what more can be done. And this kicks into my last point, which is providers are human beings. When they hear things like that, it is inevitable that they will also bring their own personal experiences, values, and biases into how they communicate with patients. An intensivist I work with closely, who is known to be very aggressive in their care and unrelenting in the amount of interventions they offer, in these times of COVID and the unfortunate outcomes we've had, said to me, David, I feel like I'm a monster these days, having to tell families I have nothing left to offer them. That's a very real, visceral aspect of how people see themselves that we have to be mindful of. So even though we design tools that delineate patients' wishes and ideally allow them to receive the care they want, at the end of the day, we're often also in the hands of the providers that care for them if they end up in the hospital. And we have to respect and work around and help massage the message of a paradigm of care that's acceptable to them, despite things being fairly black and white from the patient standpoint. So I'll leave it at that. Thanks for bearing with me and listening to that story. I want to make sure I leave enough time for all of you to ask questions to myself and all the other panelists as well. So Carol, I'll kick it back to you.
Hey, thanks so much. That was just excellent. If everybody could turn on their cameras right now, I see mine is frozen. So, but if everybody else can join. Like that, Julie. So we have a couple questions, and the first one is about mobility. With people being so mobile now within the United States, what do we do about people that want to travel from state to state?
Can I take at least the first part of that?
Sure.
So it's really interesting, again, because every state has their own laws if we're talking about advanced directives. I would say many states sort of allow, they call them interoperability laws for advanced directives, that they'll accept them across state lines. Some states don't. I'll just sort of put in a plug because of all of this and some of the work that we've done with Prepare for Your Care, is that because we have easy to read advanced directives for all 50 states, if somebody were to create their advanced directive on Prepare, say in California, and then they travel to Florida, all they have to do is click a button for Florida and it will like bring up that state's laws. And we went there because this was an issue, particularly for people who are visiting family or snowbirds or people who are traveling around the country. mean, David, I'd be interested to hear your viewpoint, because I've also heard from clinicians that they're so desperate for any information about this person that it may not be the deciding factor, but it really helps in that bedside decision making, even if you're getting an advance directive from out of state.
Yeah, I'll take it next, Rebecca, and then hand it over to else like to chime in. I do think in matters as critical as these, any information is better than not. I know some states have exchange agreements about their post or most documents. I think ultimately all of these conversations need to be confirmed when they arrive to the emergency department. And it does vary by institution how forgiving the hospital allows their emergency departments to be to follow a pulse without somebody to confirm those wishes at the point of care. That being said, something like an advance directive, it's challenging, and I don't want to beat a dead horse, but the thought that when a lot of advance directive languages, I wouldn't want to be maintained in a state, where I don't have XYZ quality of life. I would not want to prolong my life. However, in that moment of crisis, many emergency physicians would find it difficult to prognosticate what happens on day 3, day 4. And so the advance directive is not nearly as valuable as something like a POST or MOST form, which at least should have indicated a specific conversation around code status happened, meaning a breathing machine and CPR, what happens when your heart stops or when you can no longer breathe on your own. I'm happy to talk more about that or kick it to someone else.
Carol,
We have a few minutes.
oh, there she is.
Oh,
Okay.
go ahead. Yeah, I turned off my camera because I was stuck. I don't know if it'll. I can try it again.
Your voice is coming through loud and clear, so you can just continue.
Great. So I have a question. There are so many people on this call that are parts of systems, whether it's healthcare or IT or whatever. But there's also been mention about the community and about primary care physicians. And we know that up until recently, this education about having these types of conversations was not routinely taught in medical schools. It's still not 100% from what I understand. And plus, in the practice, they have a lot of challenges as well of time constraints and throughputs. And even if they do have the conversation, how do they share the documents? So from a community perspective and from people in primary care offices, what kind of insights and advice could you give our colleagues?
Can I start with that one? As a primary care provider, geriatrician who sees patients who have like 40 million medical problems when they walk in the door, how do you squeeze in advanced care planning, in that time frame? I'll just give you a couple of just practical pieces of advice. One is, again, on our Prepare website, we have materials for providers with like a 3 simple step process with words that people can say. They don't have to go through training. They don't have to guess what to say. And they can just do 1 step at a time over multiple visits. It's like a 1-page document. Anyone who's listening, it's for free. So feel free to give that to your clinicians to make it easier. And I think to that point is, oftentimes in primary care, there are so many things to do, and maybe you can't do it all yourself. So sometimes I will ask my social worker to help me, or again, we've created materials that are meant to be so easy to use that people can at least start looking at the advanced directives or going to look at video stories on our website. And I actually give people homework. So I'll say, we don't have time to talk about this today. I'm going to give you a little bit of homework. Look at this pamphlet, look at this advanced directive. We're going to talk about it next time. And that can sort of decrease the amount of time when that person comes back, and then you can kind of chunk away at the advanced care planning over time. But that's how I've worked it into my practice.
Can I just add to what Rebecca said? And I want to emphasize the really important point she made is serial conversations are often what are needed. These are tough topics. Nobody really wants to talk about this. It's not in our culture. And yet various health systems have become privy to the fact that value-based care has to address the care utilization at end of life, and they don't want to deliver care that's unwanted. Something that I also find helpful is with serial conversations and having them early before you get sick, it is often less threatening to patients and their families because they still maintain a sense of control. They're not in a hospital bed looking up at someone speaking physically down to them about issues that are scary and that they may be hearing for the first time. When Rebecca has these conversations with people, they go home and they talk to their loved ones, their kids, their parents, their siblings, and not only does that serve the purpose of making them own their decisions, it also helps their surrogates understand their wishes too. So in a moment of crisis, when they're called upon, those people feel like they're just conveying what's already been told them versus making a decision on the loved one's behalf. And so I think the push to having these conversations out of the hospital as early as possible, and ideally, yes, with non-physicians, non-healthcare providers is entirely appropriate. One vendor that we use here is Scripps, not promoting them in any way, but it's called Iris Health Plans, and they do tele-advanced care planning, calling people in their homes to have these conversations earlier.
And Julie,
And to,
I was just going to say,
Julie, were
Julie,
you going to
you
say?
had a great example of some of those conversations that you had with your family members sort of beforehand and how important that was.
Definitely.
I agree with that. I think it needs to be a language that's built into a doctor's entire conversation with a patient. I think making it this separate thing and a document and homework, it's something that nobody wants to do, especially when their doctor tells them to do it, because that has massive implications. And I also think it might be a good time to, if it has to be done that way, to maybe involve a family member, or if they've already chosen an advocate, and bring that person into that conversation at that point. It might ease it up a little bit.
Yeah.
And
This is Cheryl, and I was going to ask you, Dr. Ling and James, to wrap it up. Do you see any possibility in the future of community-based facilitators being reimbursed instead of having it come through physician offices, but actual community-based certified facilitators being paid?
Yeah, so this is Sherry. I mean, I will start, and really curious about other responses. But one of the challenges that Medicare has is Medicare providers, who they are, what flavor of providers they are, that and who can be paid by Medicare directly is laid out in statute. And that statute was created long ago. And, so there would need to be some changes to that if it were a direct payment. However, having said that, there are new models of care, alternative payment models, where it is the practice, the group, the system that is the entity that is paid. It actually works it could work in a way that really supports team-based care, which is as a geriatrician, that's kind of what we grew up with, and we work better as teams. And David, you're absolutely right. Coming back to the conversation over and over as the course of time proceeds, is a really important opportunity to really seize. Because, as a dementia care provider in a specialty clinic within the VA, I can't tell you, it seems like just a collection of missed opportunities over time, where, all we have sometimes is the caregiver. And, it is a relief to the family if in those times when they know what it is with certainty that the person with dementia actually would have wanted, and for us as clinicians to be able to give permission to listen to that is also really important. So really appreciate the conversation today, and again, it's been an honor.
Okay. Well, with that, we're going to close out this session. I could talk to you all afternoon. It was a great session. Thank you all so much.